Thank you, Dr. Han and Dr. Salke, for the honor of presenting today. Got it. Nothing to disclose here. So today I'd like to review with you guys some of the high-level evidence surrounding minimally invasive gastrectomy that's been produced over the last 10 to 15 years internationally. I'm going to do that through looking at some of the randomized controlled trials as well as some of the case-controlled studies that have been produced in the West. And then in the end, I'll review some of the available data regarding robotic surgery. So as we know, the global incidence of gastric cancer has dropped recently from being in the 4th position as the most common cancer to the 5th position. Despite this, gastric cancer remains the 4th greatest cause of mortality from cancer deaths internationally. When you look at the incidence per 100,000, 70% of the world's gastric cancer is found in Eastern Asia, with an incidence in Korea specifically that's extremely high. 41.8 per 100,000 incidence of new gastric cancers per year. Compare that to the United States, where we have an incidence of 7.4 per 100,000. And if you look at men, the incidence in Korea is starkly high at 62.3 per 100,000. Again, comparing that to the United States at the incidence of 10 per 100,000. To put it in some context, the incidence of colon cancer in the United States is equivalent to that of gastric cancer in Korea. And in the United States, we have several societies which advocate early colonoscopy. Colonoscopy is a funded screening modality in the United States, similar to the funded screening programs that occur in Eastern Asia for gastric cancer. So it should be then no surprise that almost all of the randomized controlled trials that have been conducted for gastric cancer are born in the East, with one exception, which is Dr. Heischer's group in Italy that produced a randomized controlled trial. That is the only randomized trial that doesn't originate from the East. So I'm going to go through all these trials pretty rapidly. But the trials have several things in common. In large part, they all represent early disease. As you can see here from the tumor staging, it was by design at the time when these trials were being designed. The safety of laparoscopic versus open was being questioned. So by design, most of the trials were early T1 disease, or at most T1 and 0 disease, or T2 and 0 disease. There are a couple of important exceptions. Again, Dr. Heischer's group had 58% advanced cancers. More recently, Dr. Kai's group in China had all advanced cancers. That trial was specifically designed to look at the difference in outcome of advanced cancers. And finally, the most recent trial from China had 76% of their cancers were advanced, as you can see here. Again, most of the trials were designed to predominantly address distal disease. In fact, all the trials were designed to address distal disease. There are a number of out-of-protocol additions for total gastrectomies. In total, in all the randomized trials, 52 cases of total gastrectomy were reported. But when we discuss these trials, they really all are distal disease. Its applicability to the United States, where we're seeing much less distal disease and much more proximal disease, sort of is important to note when you look at these trials. And so one of the major questions early on was whether or not we were able to do an adequate lymph node dissection laparoscopically. And so all the trials have looked at that. And as you can see, in red here, you have the trials that had some statistically significant differences in lymph node harvests. Generally speaking, there's only 2 trials that showed a difference, but in both of those trials, adequate lymph node dissection was achieved. In fact, if you look at all the trials, 100% of them show adequate lymph node dissection of 15 or more nodes. So that really has pretty easily been debunked as being a concern. And then when you looked at short-term outcomes, there was no difference in any of the trials in terms of mortality between open and laparoscopic. Morbidity tended to show worse morbidity in open versus laparoscopic. 2 specific examples are Dr. Lee and Dr. Han's trial, which showed a significant difference in terms of complications related to pulmonary disease, and Dr. Kim's trial, which showed a statistically significantly higher complication rate. And if you look at the N for that trial, in comparison to all the other trials, it's a pretty significant number. And we'll go over that a little bit more in detail later. EBL also, with the exception of one trial, at least tended to or was more significant in the open arms. And length of stay was sort of all over the map, but in terms of number of days, but generally speaking, really tended to favor laparoscopic versus open. So those are the short-term outcomes for all the 9 randomized control trials that have been produced that are of high quality. So, there's an evolution in terms of these randomized trials. The earlier trials tended towards the smaller numbers. And because of that, there was several criticisms, which gave rise to some concerns. One was many of them were single-center trials with small numbers, and there was a lack of long-term follow-up in those patients, or in those trials. So the Korean Laparoscopic Gastrointestinal Study Group, Surgery Study Group, was born out of these concerns. One, given the fact that the incidence of gastric cancer is so high there that there was an ability to do a good randomized controlled trial series. And so the last publication from that group, the most recent publication was in Annals of Surgery in 2016, was from the class group. And the group is 13 university hospitals with 15 very experienced surgeons, many of whom are in the audience today. They specifically looked at early distal gastric cancers. You can see the staging here. The preoperative staging was done using EUS or CT and/or CT scan. And they excluded patients with an ASA greater than 3 or anybody who received neoadjuvant chemotherapy. In terms of D2 dissection, there was a statistically higher proportion of D2 dissections in the open group versus the lap group. And the lymph node harvesting, however, was not very different. Although it was statistically higher in the in the open group, overall the numbers are still well within the oncologic requirements for adequate lymph node dissection, and certainly higher than most of the lymph node dissections you see in the United States. The morbidity was also important. It was statistically significantly higher in the open series. You can see here a 6% difference. But if you look at the actual complications, the majority were related to wound complications, specifically dehiscence. Now, wound complications may not sound like much, but as you know, many of these patients who end up upstaging may require adjuvant therapy, and that the longer patients wait for adjuvant therapy, the less likely they are to actually begin or complete it. So this actually becomes a very important and relevant fact when you start looking at trials down the road. So when they looked at a multivariate analysis for post-op morbidity, having an open operation increased your risk by 40% of complication, as previously shown. And having greater than 3 comorbidities significantly increased your risk as well by almost 3.6-fold. So really what we can take away from this last publication is that the post-operative morbidity significantly increased in the open group. Those are great, that's a great example of an excellent, well-powered study showing short-term outcomes in terms of morbidity. However, really there's no published yet long-term outcome in terms of oncology in early disease. When you look at the previous trials, looking back as far back as 2002 and 2005, Dr. Hayashi and Dr. Kitano's randomized trials, they offer the longest oncologic outcome that's reported. With LAP, Dr. Hayashi's group, 39 and 45 months, and Dr. Kitano with 24 and 18.8 months. In all, there were 56 patients total in these trials, none of whom had any recurrence at the follow-up times. There's been no follow-up publications related to these trials, so we don't really have any data other than that right now. So, based on these 9 trials, what conclusions can we draw? And I think that minimally invasive gastrectomy in early and in distal disease is really, in some ways, equivalent to open gastrectomy in terms of ability to harvest adequate number of lymph nodes. It's at least equivalent, and in terms of producing adequate margins, is at least equivalent. Surprisingly, if you look at the data, well, maybe not surprisingly, it is actually superior to open gastrectomy in terms of reduced complication rates based on the class data, and as well as reduced intraoperative blood loss. And we know both of these factors are actually directly related to long-term outcome in terms of survival. And that's been proven through hepatobiliary or research in hepatobiliary outcomes as well as colorectal outcomes for cancer. So that's looking at early disease. What does the data show us in terms of advanced disease? Well, probably the best or the sort of most landmark study is Dr. Heischer's group in Italy. They looked at 30 patients in laparoscopic versus open, of which nearly 60% of those patients were advanced disease. And about 70% of those patients received a D2 dissection. When they looked at their postoperative morbidity, there's no statistically significant difference in terms of complications, including between laparoscopic and open, including pulmonary issues. This actually mirrors the other trials in the literature from Dr. Kine, Dr. Hugh, looking at with much larger ends. There was no, in those studies, there's no statistically significant difference in terms of complications either. Dr. Heischer's group is unique in that they were able to look at, it's really the only study out there that looks at 5-year survival in advanced disease. And as you can see, there's no difference in overall survival, whether the operation was done lap versus open, or disease-free survival at 5 years. And so this provides really the best data that we have right now, currently, in terms of long-term outcome, comparing lap versus open for advanced disease. When we look at the data generated out of the United States, really the best data has come from Dr. Strong's group at Memorial Sloan Kettering. And they were able to look at their experience from 2005 to 2013 with 87 minimally invasive gastrectomies. It's a case controls trial or a study, so they matched their cases for age, path, stage, BMI, and procedure with 87 open cases done at the institution during the same time frame. 37% of these cases were advanced disease and 23% were proximal tumors. It's important to look at that, what was excluded from this trial. And 42 patients were excluded for conversion to open. Most of these were for tumor-related issues, either whether there were adhesions to the lesser sac or to the extension to other organs. But unlike perhaps many of the Eastern studies, 7 of those patients were converted just because they were too much intra-abdominal fat to deal with. And then there was 4 patients who were converted for a proximal margin on frozen section. That's an interesting point because when they looked at their margin status, one of the downsides of this trial was that if you look at the R1 resection, there was actually a statistically significantly higher rate of R1 resections in the laparoscopic group. However, the lymph nodes were equivalent, and again, if you compare the lymph node retrieval rate in the Western series versus all the Eastern series, there's a significant difference in the total number of lymph nodes retrieved. However, in this study, open versus lap, there was no difference in terms of lymph nodes being harvested. When we looked at some of the operative characteristics and complications, there was a fair amount of total gastrectomies in this trial. The operative time was obviously much longer for laparoscopic than open, on average about 70 minutes longer. Blood loss was about 100 or 50 cc's less for laparoscopic than open. And minor complications that occurred in the first 30 days to 6 months were statistically significantly less in the laparoscopic group than in the open group. However, if you looked at more major complications, those tended to be the same throughout both open and laparoscopic. That may be in part, so the difference in complication rates, even though they were just minor, may be in part responsible for the really exceptionally high number of patients who were able to move on to adjuvant therapy in this group. Now, obviously, the group at Sloan Kettering is fairly aggressive in terms of pursuing adjuvant therapy, but when you compare the rate of adjuvant therapy in this cohort versus the rest of the country, it's nearly double the number of people. And there was a statistically significant difference in terms of those patients who were able to move on to adjuvant therapy. that favored laparoscopic surgery far more than open surgery. So it could be that the patient's recovery being smoother, having less complications, allows them to proceed to adjuvant therapy. And in terms of survival, there's no difference in survival between lap and open, either in recurrence-free survival and overall survival. And this is pretty early data because the mean follow-up time for laparoscopic in this case control study was only 11 months. So although we have some data here as far as 72 months, it's really the mean's only 11 months for the laparoscopic. So the poor adoption of minimally invasive gastrectomy in the West may have something to do with a lower incidence. Obviously, there's lower incidence, lower volume. It's a very difficult learning curve. Some authors quote between 40 and 100 cases to achieve the same results laparoscopically versus open. For many surgeons, it would take 10 years to do that many cases. And the D2 dissection obviously is complex, and it's something that's difficult skill to acquire. And so for a while, people have wondered whether we can make robotic surgery a catalyst for improving adoption. Certainly there are advantages to the robotic surgery, as Dr. Kim pointed out. The 3D vision definitely helps. Degrees of freedom of mobility of the instruments, improved precision. Here it says suturing, but really in dissection is probably one of the major advantages, as well as the improved visualization. But of course, everything good comes with something bad, and the bad part here is the absence of any haptic feedback. It's extremely expensive to start a program, and there's really no proven benefit at this point. So worldwide adoption, none of those negatives have stopped the adoption of robotic surgery. It's an exponential growth both here and abroad of increasing cases of robotic surgery. Thankfully, the class surgeons have conducted a multicenter prospective comparative study looking at robot versus laparoscopic gastrectomy for cancer. Wide range of experience between 4 and 450 cases per surgeon. Most surgeons had about half the surgeons had greater than 30 gastrectomies under their belt, and the primary outcome was really morbidity and mortality. I'll skip to the results here. Yep. So operative time really was significantly longer in the robotic group, and as you can see, the cost was statistically significantly different. So you're getting longer OR times for more money spent, was the conclusion. There's no difference in complication, even though the robotic group had a slightly higher rate of advanced cancers. One more slide after this one. 8 studies in total in this meta-analysis looking at 1,875 patients show no difference in complications between lap and robotic, no difference in mean lymph node retrieval and adequate margins, but distals were favored robotically. Distal margins favored robotic. So, in terms of looking at this learning curve thing, this study looked at one single surgeon's learning curve, and he noted that after about 270 cases of laparoscopic surgery, his operative times evened out, meaning that looking at running average time, 270 cases it took to really become an expert versus 95 cases with the robot. So that may be the conclusion there. So in conclusion, I think level 1 evidence supports minimally invasive gastrectomy for distal and early gastric cancer for sure. Robotic surgery is still more costly, takes longer, but may shorten learning curves. And they're still building data to support, we're still building data to support short-term oncologic outcomes in advanced gastric cancer. Obviously, the class 2 studies will be very important to see. Thank you very much for your time.